So we will be talking about the difference between latent TB infection versus active TB disease, and then talk about the clinical presentation of active TB disease. So there is a difference between latent TB infection and active TB disease, and this is an important concept. So for any infectious disease, there is an interplay between the organism, in this case Mycobacterium tuberculosis, and the host, the human host. So on the left-hand panels, you see two columns where the infection has been completely eliminated. So in someone whose innate immune response is able to control the infection and then completely eliminate it, this is again when the bacteria reach the alveoli and the macrophages phagocytose the bacteria, the phagosome-lysosome complex is able to eliminate the bacteria. The infection is eliminated and they do not have TB infection. Those people have no symptoms, they have no infection, and they do not need treatment. The second column are people who then require their acquired immune response, that's the T cell response, to control the infection and then eliminate it. So after that phagosome-lysosome complex is not able to control the infection, dendritic cells recruit the T cells. The T cells form with the acquired immune response are able to control the infection and eliminate it. Those people, because our TST and interferon gamma release assay rely on the T cell response, those tests will be positive even though they actually do not have infection, and they do not need treatment for latent TB infection. However, it's very rare that people are able to eliminate the infection on their own with their immune system. So the vast majority of people will develop latent TB infection after exposure. And so that's when the acquired immune response with the granuloma walls off with the bacteria at the center with the caseating necrosis. There is still mycobacteria there, but because the infection is walled off, there's no spread of the bacteria elsewhere and there's no active disease. The person doesn't have symptoms. So these people have latent TB infection. Their tuberculin skin test and interferon gamma release assay will be positive, but they have no symptoms and they do need treatment for latent TB infection to prevent progression to active TB disease. So there is an entity of subclinical tuberculosis disease where this is a little bit tricky, where the immune system is not able to control the infection. The bacteria do escape the granuloma and go elsewhere into the lung, but the patients are subclinical. They do not have symptoms. So this can be a tricky entity to diagnose. But more commonly, we see active TB disease. These are people where, again, the mycobacteria have escaped the granuloma. They go to the lung, they go to the lymph nodes, sometimes the rest of the body. They have symptoms. They have fevers, chills, night sweats, cough, hemoptysis, and their sputa will be positive, and they need treatment for active TB disease. So again, we talked about the stages of TB infection. So a very small minority of patients, under 1 to 2%, will be able to eliminate the infection fully with their immune response. The vast majority develop latent TB infection, and over someone's lifetime, the risk of developing active TB disease from latent TB infection is about 10 to 15%. It's about 5 to 10% in the first 2 years after being exposed to TB and developing latent TB the TB infection. So it's highest right after the infection occurs, and then it drops over time. So who is at risk for developing active disease? So if someone doesn't have any risk factors for reactivating or progressing to active TB disease, again, the risk is about 5%, 5 to 10% of the first 2 years after infection, and then about 10% over a lifetime. However, if someone has diabetes, their risk is 3 times as high as someone who doesn't have any risk factors. So it's about a 30% chance that they will progress to active TB disease over their lifetime. So someone who has latent TB infection and diabetes generally should be considered for treatment of the latent TB infection to prevent progressing to active TB disease. And then those who are co-infected with HIV and TB have a very high rate of progressing to active disease. The risk is about 7 to 10% per year. And so over a lifetime, really over 10 years, their risk is 100%. So that's why all patients living with HIV need to be screened for latent TB infection. And if they are positive, need to be treated as soon as possible so they do not develop active TB disease. So this is a nice calculator that comes from McGill University in Montreal. which basically you can input in details of your patient, and it will give you information about the likelihood that this is a true positive test, annual risk of development of active TB disease, cumulative risk of active TB disease, and if they're treated with INH, the probability that they could have hepatitis. So in terms of the clinical presentation of active TB disease, we'll talk about pulmonary TB, extrapulmonary TB, and CNS TB. So the symptoms of pulmonary TB include fevers, chills, night sweats, weight loss, anorexia, fatigue, cough, and hemoptysis. The physical exam findings, however, are nonspecific. Sometimes you might have an abnormal lung exam, and in those who have advanced untreated pulmonary TB, they can have cachexia, which is why the old name for TB consumption came about, because people literally look like they were being consumed from within by something. In terms of imaging findings, so it can take any radiographic morphology, but most classically you have that cavitary lesion, again, when that granuloma can burst into a bronchus and develop a cavity. We use a screening chest x-ray and then CT chest to look for pulmonary TB. And the classic findings are a nodular infiltrate in the apical or subapical area of the upper lobes or superior lower lobe, again, where airflow is highest, and that's where the mycobacteria tend to land. So here are some chest x-rays here. You can see on the left infiltrate in the right upper lobe, and then on the right hand side there is infiltrate in the superior part of the right lower lobe. And then this is a CT chest showing miliary TB, so it's quite subtle, but if you look closely, there are small little dots everywhere in the lung parenchyma, which represent tiny nodules of TB, and this is where the name miliary comes from. It comes from millet seeds, and so you can see that these tiny nodules do look like millet seeds. So again, the classic finding, cavitary TB, we can see that cavity on the right, in the right upper lobe on the x-ray where you can see air, and then same thing on the CT chest, you see that thick wall with the air in the middle. In terms of laboratory findings in pulmonary TB, again, nonspecific, you might see normocytic anemia, hypoalbuminemia, hyponatremia from SIA. The way we diagnose pulmonary TB, we use 3 sputa for AFB smear and culture. Ideally, they should be obtained early in the morning or at least 8 hours apart. Induced sputa give a good sample, and if someone is not able to cough or produce sputum, then we recommend bronchoscopy and BAL. Patients living with HIV have a lower bacillary load and can be smear negative. So if your pretest probability for someone living with HIV with TB is quite high, then we would not be reassured by negative smears and would instead wait for culture. In children who cannot cough, they often swallow the sputum, and what we do is we use the gastric aspirate, because then the sputum with the bacteria have been swallowed, so we'll find it that way. We also use molecular diagnostics, MTB NATs from the sputum, which we'll talk about later, and if someone's undergoing a biopsy on pathology, we will see necrotizing granulomas with AFB. So for extrapulmonary TB, this is much rarer in patients living without HIV. 15 to 20% of TB cases in HIV negative patients are extrapulmonary. However, in patients living with HIV, nearly half to 60% of TB cases have extrapulmonary manifestations, which can be combined with pulmonary TB. The most common form of extrapulmonary TB is TB lymphadenitis, because again, the mycobacteria go to the lymph node system after escaping the lungs. Pleuritis and pleural effusions, which are considered extrapulmonary, is another form. GU-TB is actually a common cause of infertility in low and middle income countries. There's GI-TB, vertebral and joint TB, and skin manifestations of TB. So TB lymphadenitis typically is seen in younger individuals, such as children and young adults. It presents with a painless unilateral cervical lymph node with erythema overlying, sometimes with drainage, which is then described as scrofula. Patients typically have a positive tuberculin skin test or interferon gamma release assay. TB lymphadenitis is typically paucibacillary, so the smear and the molecular diagnostics, the NAT, may be negative from a sample, but the culture typically will turn positive. The imaging will show necrotic lymph nodes, and the diagnosis can be made by biopsy with the path showing necrotizing granulomas and cultures. So greater than 90% of TB lymphadenitis will occur in the head and neck chains. These patients are often very well appearing with no fever, and only 20 to 30% have an abnormal chest x-ray. So here's an example of cervical TB lymphadenitis, where you see the cervical lymph node with edema and overlying erythema. And here is an enlarged lymph node in the axillary space with overlying erythema. So pleural TB is considered extrapulmonary disease. So it is much rarer in resource-rich countries. Only 3 to 5% of TB patients in the United States or resource-rich countries develop pleural TB, but it's more commonly seen in patients living in TB endemic areas. It's a very difficult to diagnose entity, and the reason is because the yield from pleural fluid cultures is often low. And so we really rely on pleural chemistries and the characteristics of the cell count in the pleural fluid to help us make the diagnosis. So typical features on the pleural chemistries include elevated LDH and protein, increased white count with a lymphocytic predominance, and then we use the ADA, the adenosine deaminase, to help make this diagnosis. So if the ADA is greater than 40 in someone with a lymphocytic pleural effusion, it has a very high positive predictive value, 98% for TB, pleural TB. Conversely, if the ADA is low, it has a high negative predictive value of almost 99%. If one is able to get a pleural biopsy, then that can be sent for pathology and culture. The culture rate positivity in the pleural tissue is 76%. So here is an example of a schematic, an approach to how to diagnose pleural TB found in this journal article. So it's a helpful practical approach. So another manifestation of TB is vertebral TB or Pott's disease. So this is typically found in the thoracic vertebra, which makes sense anatomically. It's spreading from the lungs, so it goes to the thorax. It is initially disc sparing on imaging, but then in advanced vertebral TB that's not treated, it progresses to destruction of disc. So if you see osteomyelitis with disc destruction, it doesn't mean that it could not be vertebral TB. It could just be advanced vertebral TB. If the patient has soft tissue disease, they present with a cold abscess, meaning that there's no warmth or erythema. So here's an example of Pott's disease on the left where the disc is more spared, and then on the right in panel B where the vertebra are clearly affected and so is the disc. And then there are dermatologic manifestations of TB. They are classified into primary, secondary, and tuberculosis. So primary cutaneous TB is direct inoculation of TB from the droplets. So this is an example of a child who basically the parents were kissing the cheek and the droplets from the mouth directly inoculated the child's cheek. It can also happen when someone's coughing into their hand and then the droplets directly inoculate the hand. So in this case, it's localized infection, so the PPD may be negative. In secondary cutaneous TB, this can be scrofula from the lymphadenitis, or someone has hematogenous spread and they have pustules and papules. Lesions, if these are biopsied and cultured, will be AFB and PCR positive. And then finally, you have tuberculosis. So this is actually an immune reaction to TB. So examples include erythema nodosum, which is seen here, where you have painful nodules on the lower extremities, or erythema induratum of Bazin. This is an immune response. So if these skin lesions are biopsied, they will actually be AFB and PCR negative. And then there's also CNS TB. Various manifestations of CNS TB can occur, including a tuberculoma, meningitis, classically involving the basal part of the brain, and cranial nerve palsies. And these patients can also present with SIADH. So here's an example of a CNS tuberculoma. You can really see a thick-walled cavity there in the brain.